Welcome to the Benzo Free Podcast, your home for an honest, straightforward, and personal discussion about anti-anxiety drugs, their effects, and how to deal with dependence and withdrawal. Whether you have taken benzodiazepines, Z drugs, or any other tranquilizers, know someone who has, or you just want help dealing with chronic anxiety and insomnia, this is your podcast. I'm your host, D.E. Foster, author of the book, Benzo Free, The World of Anti-Anxiety Drugs and the Reality of Withdrawal. I'm so glad you joined us today. Please stick around and let me bend your ear for a few minutes. It just might feel a little better on the other side. Hello there, this is D, and welcome to episode 70 of the Benzo Free Podcast. 70. That's a few. I've been doing this for a little while. It's pretty cool to reach 70. It's pretty cool. In case you didn't know, this episode is actually part 2 of our 2-part series. That is the conversation with Dr. Robert Valuck, a pharmacologist, about benzos, about FDA, about addiction, dependence, about physiology, about all kinds of good stuff. So please stay tuned and catch the second part. If you haven't listened to the first part, you might want to go back and listen to the previous episode of this podcast, which is episode 69, and you can hear the first part of it. Yeah, that's what I wanted to say. I feel like I just spoke with you, because I just did. You may notice this is the same shirt I had on in the last video. That's because I am recording these back to back. And as I mentioned in the last one, I recorded them back to back and then found out I had a mic problem and have to record them back to back all over again. So here I am, but I'm going to wrap this up and it's going to be good. I don't have that much to talk about in the intro because primarily there's a lot to cover. We got a good long benzo story to share with you. And we also have, of course, the interview with Dr. Valuck, so I don't want to take up too much time. But I still want to ramble a little bit because it's what I do. And one of the things I noticed, I was talking to a friend the other day, a mortgage broker. So we're talking about that, and it was funny because one of the conversations the mortgage broker had from me when I was talking was she said, "What do I do?" And I told her that I actually host a podcast and a YouTube channel on anxiety and anxiety medication. You'd be amazed at the number of people who that catches the interest of, because I mean, it can be anybody, but somebody always says, well, that's me, or that's my brother, or my cousin, or my uncle, or my dog, or somebody else I know suffers with anxiety or is on these drugs or whatever. It happens all the time. In fact, that's one of the reasons for a long time I wasn't telling anybody what I was doing. I kind of am private that way sometimes, plus I don't want to bore them. But now I'm not going into a long spiel about it, but if they ask me, I just flat out say, well, I do this and this, and you'd be surprised, probably half the time, if not more, I wind up into conversation about somebody who's struggling and wants to talk through things, and it's really great. And this happened with her. And not only is she struggled with anxiety, but also anti-anxiety medication, and is on it. So I backstepped a bit and said, okay, tell me about it, and I walked her through it, and I said, be careful of the horror stories and this, and said, if you decide, and of course it's your choice, if you'd like to come off a benzodiazepine, and I couldn't advise her, but I told her work with a doctor, and if it's something she wishes to pursue, to make sure you do a slower taper, and that, you do it properly. Here's the information. I gave her some information on my website, and it was really interesting. And then she spoke with my wife today, and my wife shared with me that she was really excited about it because we had this wonderful connection, this wonderful conversation, and we were laughing about the things we go through and stuff like that. And she really has a good, very centered, kind of spirit and attitude about this. And so it's nice to see her, shine and kind of get excited. And she said she's even taking a second look now at some of her priorities. And that really hit me because that's exactly what I did in benzo withdrawal, was take a second look at some of my priorities, because it was my priorities that kind of got me into this place in the first place. I mean, I didn't sign up for the drug, and most of you didn't either. Mine was prescribed for stomach medication. But I took it for 12 years. And in those 12 years, I never once, or in those first 11 years until the end, never once looked it up on the internet. Never stepped back to ask what I'm taking, why I'm taking it. Am I getting benefits from it or not? Or is it doing anything to me or what? I didn't ask. I was too busy. And I think we all get too busy, and we all get so busy chasing that thing: success, fame, money, family, spouse, the white picket fence, the whatever it is. We're all so busy chasing that because we are so convinced that when we get there, life will be better. And yet it rarely is. It rarely is. And for some of us, it takes an event like benzodiazepine dependence to break us out of that race, to break us out of that mold, to help us step back a second and say, wait a minute, where am I going again? And why am I sacrificing the present moment? Why am I sacrificing all the stuff that is around me, all these wonderful things that I'm just not seeing, not hearing, not experiencing, for that thing that I think is going to make me happy one day? And why don't I realize that inside, deep inside of me, that happiness, that joy, that meaning already exists? That's what I came to. And I started to reshift my priorities. And that's what she's doing right now. Kind of looking at her priorities. She even mentioned that she's looking at why she's working so hard. With the lower rates right now, most mortgage brokers are working very hard right now, and she's getting exhausted. And I feel for her. But it's interesting because we keep having that elusive dream that's been sold to us. That if we could only have this, if we could only have that, if we only were that person, if we were only doing this, we would then be happy. But there is zero evidence that fame, fortune, money, success create happiness. There's none. There really isn't. And yet we're sold this story. We think it is, and we pursue it. So I think it's just important for us, at least for me, and I'm talking for me here because I'm not telling you what to do. I never want to be doing that. I'm telling you things that I've learned that might help me. Maybe one of those might help you too. Maybe they won't. Each one of us has our own path, and I would never get on here and tell you my path is the way you should take, because it's not. I will never tell you should believe what I believe, because those are my beliefs, not yours. I'll never tell you what values you should have, because those are my values, not yours. You got to figure that out for yourself, as you should. But sometimes stepping back and taking a look at the big picture and saying, where am I going? And what's it going to be like when I get there? May be good questions to ask. Maybe good questions to ask. Let's move on. Okay, our format today is going to include the introduction, which you just heard, our Benzo story, our feature, and our moment of peace. Our feature, of course, is part 2 of the interview with Dr. Robert Valuck. It's a great one, so please stay tuned for that. And before we move on, don't forget we need your help. We need feedback of any kind. We truly want to hear from you. There are 4 ways you can provide feedback. 1, comment on the YouTube channel. That helps a lot. 2, comment on the podcast post. 3, I'm going to look at my notes for this one. Oh, yeah. Our feedback form at benzofree.org/feedback. And 4, okay, what was 4? Oh, on our podcast carriers, because that does help other people find us. See, sometimes I try to remember without having to look at my notes. My memory, my cog fog, all that good stuff sometimes gets in the way. While you're on the website, please don't forget to sign up for our mailing list at benzofree.org/subscribe. And if you wish to support what we do here, and I really appreciate that, we are entirely donation driven here, so any little bit you can help, please visit our donation form at benzofree.org/donate. I'm getting ready to launch the new website. It's really, I think, looking good. I think you're going to like it. So let's move on to our Benzo story. We have one story today. It's from Chris in Melbourne, Australia, down under. I love these ones from all over the world. It's great to have that kind of diversity and variety on this show. His story includes a variety of benzos, mixing it with some alcohol, a little partying when he was young, but also ends with a positive note. And I think he's got a good attitude going into all this. Chris writes, I've always been an anxious person, and this was compounded mid-2019 with the birth of my daughter. And sleep going out the window. I have a history of alternating periods of binge drinking and sobriety, major partying as a teen, early 20s. The drinking is out of my system for the most part, but I suspect it's contributed to my ongoing issues with benzos. I work a high-pressure job, which comes with a lot of stress. And I've learned over time that I don't always cope well with that stress. Over the years, I've occasionally gotten a prescription of diazepam or temazepam for sleep, stress, flying, and I would always end up taking the pills almost every day until the script runs out. Doctor would usually give me 10 at a time. And I never really thought anything about it. Late 2019, I was nearing the end of a 10-pack of Valium and used the last one for a flight overseas for work. I had been experiencing intermittent derealization, and I never connected it to the benzos. I thought it was stress or sleep related. But I did notice that a couple of beers would make me feel better. I was in another country for work and had no access to benzos and began feeling very unwell over the following days. Insomnia, nightmares, slurred speech, muscle twitching, stiffness, bad brain fog. I thought I must have some kind of serious neurological disease or something, but same thing. A few beers and I'd feel fine. I happened to get some Klonopin from my work doctor. Didn't know it was a benzo or anything like that, or even what a benzo was. But they made me feel fine again. I didn't join the benzos and how I had been feeling together at all, and was mostly down a hypochondria black hole. I returned to Australia and went to the doctor, who checked me over and, surprise, surprise, prescribed me with more Valium and Valdoxin, an antidepressant. I was given a packet of Xanax from a friend who had no longer needed them and had said that they are good for sleep. So, just to sum up where I am at this point, and I feel so stupid about it, I was taking Valium, Xanax, and drinking quite often to manage symptoms, which ultimately turned out to be benzo-related anyway. I proceeded to take Valium every day for around 3.5 months, somewhere between 5 to 10 milligrams a day, and occasionally topping that up with some Xanax and alcohol. I had this lingering worry that I had a serious health complaint, and still had not associated it with the medication. On the 15th of June, I was promised a new position, a massive promotion that I had been working towards for 2 years. And one key point was that I had to undertake a medical and drug test. I did some research and learned that those medications are frowned upon in my industry due to safety aspects of my work, heavy equipment, etc. So on the 17th of June, 2020, I had my last dose of Xanax and went cold turkey. I felt fine for 3 or 4 days and then hit a massive wall. I felt like I had suddenly become brain damaged, and my memory and attention span was completely gone. I had the worst depersonalization, derealization I could ever imagine would be possible. Akathisia. I also had muscle weakness on one side, bad slurred speech, confusion, depression, anxiety, muscle twitching, spasm. The list goes on, all that fun stuff that people report. In hindsight, I would have done a taper, but at the time I didn't know anything about that. I have since found Benzo Buddies Forum, which has honestly helped me so much, along with your podcast, and I will get your book ASAP. Things have been up and down since then. I am just over 3 months off benzos now. A lot of my symptoms are gone. The mental side is almost completely gone. However, I still have physical symptoms like twitching, weakness, which compound the anxiety I still have, and spasms. Doctors are hesitant to blame benzos for anything, but also think there is nothing else wrong with me and my issues are psychosomatic. I feel like things are gradually improving at a pace where I will probably be feeling pretty okay by 6 months, and that's okay with me. In hindsight, I was aware that benzos can be addictive, but I never imagined the sporadic use over 2019 would lead to a dependency, leading me to constant daily use in 2020. And I think this is something doctors really need to be more proactive with, about warning people about. This stuff is scary. Thanks again for all your great work, Chris. Oh, thanks, Chris. It sounds great at the end that you may have found the light at the end of the tunnel. I really hope that the symptoms are subsiding for you and want to continue to do that. I think it's great. I'm so glad you found the cause of what your symptoms were and that things are starting to improve. That's where so many people want to get to and find the answers to get them to the end of this and figure out what's going on and what's causing each symptom and what's going on with everything else. The complication of benzos and alcohol, they can be nasty, as we know. And we're not really warned. We really aren't. I'm sure it's in the literature. I mean, almost every medication you take says don't take with alcohol or be careful taking with alcohol, at least until you know how you react. But that's the funny part of it, is that you can take it for a while, and if you don't feel you react too badly, you keep taking it. I mean, it says right there. I think it says that on benzos. I don't remember exactly. But now we know that alcohol acts on the exact same GABA receptors as benzos. No wonder there's such a problem. Benzodiazepine, one of the still approved uses of benzodiazepines, even in short term, is for alcohol detox, because it's one of the most effective medications to help them, because there's some similarity here. But alcohol is such a factor in so many people's lives, we don't think of it, and we don't notice it, and we're not really warned about it. It just complicates things. I'm still drinking rarely. Not because I ever noticed a direct correlation or even noticed a major problem, but I got it in my brain that the less I drink, the better. So maybe that's a good thing that came out of it. I don't know. I like having a beer. But I don't reach for one as often as I used to. And I think a lot of us came out of this with that kind of attitude. Anyway, Chris, I just want to say thank you for sharing your story. Wonderful story to share, and please keep in touch. Let me know how you're doing. And I really appreciate hearing from you. Take care. Now, let's move on to our feature. Second part of our interview with Dr. Robert Valuck. Oh, this is a good one. If you haven't listened to part one, as I said in the opening, please go listen to that first. It would make more sense. It'll be more consistent. Just a reminder, Dr. Valuck is a pharmacologist, professor at the University of Colorado, director of the Center for Drug Abuse Prevention at the University of Colorado. And I shared his full bio in part one, so go back to that episode if you want to hear his full list there in that intro. And just a reminder, I recorded this on Zoom. So the video, remotely, so the video and audio aren't the best quality, but I think it's one you can totally make out and make sense, but just not the same quality as we do recording here in the studio. So I think that's it. That's enough for me to kick us off. I think we're picking up right after we finished talking about addiction versus dependence, and we're jumping in to, I think, where we are and what can be done and why is it taking so long for us to start making changes on benzodiazepines. I think that's where we are. So let's join the interview in progress.
Back in the 60s, there were already some warnings. In 79, Senator Ted Kennedy, let it set its subcommittee into the dangers of these. We had a task force from the APA come out in 1990.
Yep.
Why does it take 5 decades for us to, finally get the ball rolling on this?
I think, unfortunately, and with opioids, the body count got high enough.
Okay.
And it's all about either morbidity, and when I mean the body count, I mean the counts of people who are affected negatively, or the most dramatic version of that, of people overdosing and dying, is why opioids got the attention they did. We didn't get the attention when 115 Coloradans a year were dying of opioids. I couldn't get people to pick up the phone. That's still a lot.
That's perfect. Yeah.
But when that number became 500, 800, or 1,000 in a year, now people talk about it. And it really, that's what changed. Was
that makes a lot of sense because like with Jill Hunsaker-Ryan and the Department of Colorado Public Health and Environment, the thing that got her attention was linking the data to suicide. That's how we got her attention to start to, dig deeper into it.
Right.
So you're right. If you can tie it to suicide data or to overdose deaths or something, you're going to get the attention. But chronic suffering is so subjective. It's hard, I think, to get people's attention, especially in the governmental and medical professions, of how difficult this is.
That's absolutely true. It's just very hard to do that. And unless it's dramatic enough, and usually it's mortality counts.
Yeah.
Unfortunately, I hate to be crass, and I wish it were not true. I've spent my whole professional career wishing and hoping and trying to roll that rock up that hill without that kind of information. And it's extremely difficult to do because there's a lot of suffering out there. There really is. A lot of people in pain of different kinds. A lot of people suffering. There's a lot of people with cancer. There's a lot of people with heart disease. There's a lot of people with all kinds of things, and all of them are important.
Exactly.
And you're fighting for attention, basically, in the scheme of what we have limited resources and limited attention span. Even if we want to be paying attention, I'll pay attention 8 or 10 hours a day, and then I got to turn my brain off for a while because I only have so much attention I can give in a day. And we have that same problem. We have to compete for attention and raise this issue and show the suffering that this causes. And I think it's just hard to do. And I think the best ways are these strategies you're talking about. Link it to things that people want to talk about. Opioids and the concomitant issues, or suicide and the relation between them, which is a very strong link. And then now starting to build and show the numbers, the cases that look at the people impacted and count them. And it's difficult, but it's incumbent upon all of us, me and the scientific and medical community, to work with people like you in the community of people who are affected to say, how do we do a better job of that? How do we count this better? How do we show how this is impacting people in terms of numbers of people, the impact on their lives, the impact on their families, the impact on their work and their communities, the real impact of this thing, to elevate the conversation. And it's a hard thing to do, but I think that's the challenge in front of us.
And I think we here in the state of Colorado had kind of a perfect setup with you and the consortium and with our director of public health and everything else. It's like the pieces kind of started to fall in place to start this work group and actually, have some exciting potential for some change and some positive change.
I think we do. I think the one benefit, well, there's others, but one of the benefits of having this kind of consortium approach is we didn't view it as the opioid consortium. We always said we're the Colorado Consortium for Prescription Drug Abuse Prevention. Yeah. And we're even talking now, abuse may be the wrong word.
Yeah, I was wondering about that.
Maybe it's prescription, it's bad outcomes prevention is kind of what we're trying to do, is our hope. But even misuse, I wouldn't argue that someone who's on a benzodiazepine is misusing it. This is a prescribed medication taken according to direction. There is no misuse.
Right.
There may have been a poor job educating on risk. There may have been a poor job, managing someone, offering alternatives, really monitoring somebody very well. Certainly doing a good job with tapering. Doctors aren't taught to taper anything. They're taught to start things, but they're never taught to stop things ever in medical school. They're just not taught to do it. Wow. And I teach the pharmacology classes to medical students all the time, and I stress that with tapering medications when I do lectures on neuropsychopharmacology, that tapering is as important, if not more important. It's easy to start somebody. It's really easy to start somebody. It's very difficult to stop somebody on any of these medications. And like I tell people, if you're going to have the audacity to pick up a lighter and learn how to use the lighter, then you better learn how to use the fire extinguisher. And sometimes it's hard to do, and you think, I don't want to be a fireman. But guess what? If you're a fire starter, then you're a fireman now. And it's part of your professional responsibility to be able to do both of these things. And so we're pushing hard, like at the federal level, for better education for opioids, for doctors who get a DEA number. They have to have better education. And we're talking about that right now at the federal level to try to increase it. And my argument is they should be doing this for all controlled substances, not just opioids, because the DEA number is for opioids, benzos, stimulants, and anabolic steroids. It's the 4 main classes of drugs that are in the Controlled Substances Act.
Okay.
And all doctors should have more training about those things if they want to use and prescribe those things, because they have special higher levels of risk.
Exactly. And your comment was point on, because like you said, they starting and not stopping, as I can probably say maybe a third to half of the people I work with are polydrugged, some with 5, 6, 7 psychiatric medications. And it's really overwhelming for them to say, okay, well, I want to come off the benzo, or I want to come off this. What do I do first? And, they can't get any help. They can't find any help anywhere. Either they're afraid to touch it, or they're just the physicians are wanting to prescribe more, or the psychiatrists are prescribing more for them, or they think it's just a change in the cocktail. And I of course can never recommend to anybody whether they withdraw or not. And I always make sure I never do. But if they choose to do that and they'd like to find out what happens, it's hard for them to find somebody to work with who will reduce medication.
It is. The whole idea of whether it's reducing, stopping, switching, any of those.
Yeah.
Sort of largely calling deprescribing on the side of it. There's sort of prescribing, initiation, and there's some people call it tapering, some people call it deprescribing. But it's how do you then work on the backside of this? Because there's initiation, and then there's this arguably a midpoint where you're trying to figure out whether you're having therapeutic intended effect and whether or not you're having side effects or things that are outweighing those. And ideally, you're constantly monitoring for risk and benefit to make sure that the scales are appropriately balanced in the right direction. The benefit is exceeding the risk. And if it isn't, we shouldn't be doing it if the benefit isn't clearly exceeding the risk. And so that should be going on all the time. And then if it becomes the case where either the therapeutic objective was obtained, or somebody's no longer having benefit that is exceeding risk, and maybe risk is creeping up and benefit is waning, and now we have a point where we need to change this equation, that's where doctors struggle, is at that moment. And they're not trained well for it. So I don't blame the doctors that are already out there for their lack of training. I do take a little bit of an issue with them not being willing to say, look, this is a common problem in my practice. I see it more frequently than I expected to, so I need to get some more training for that. That's what I think. Whatever they see, because they need to learn about the new developments in diabetes and the new drugs for hypertension and the new drugs for Alzheimer's, or whatever it is. They need to learn that if they're going to treat patients with diabetes and hypertension and Alzheimer's. But they're going to continue to treat people with anxiety. They're going to continue to treat people with these disorders because these disorders aren't going anywhere. The disorders are there. The stressors, in fact,
they're increasing significantly lately.
That's very good evidence that they're increasing.
Yeah.
And if you ever wanted an increase, COVID's a perfect thing. Stress level. You want some stress level.
Yeah.
This is like the biggest shock to the system that we probably had in a better part of the century.
Well, yeah, and they were already doubling up, especially in colleges and with the youths before COVID hit. Yep. And now with COVID, I can't even imagine what the numbers are now. I know we have some initials, but it's going to be really surprising.
It really will be. So we've got this problem, and it's going to, unfortunately, I really do believe it's probably going to get worse before it gets better. But we have to be banging the drum as loudly as we possibly can.
Right.
And, signing up as many of our colleagues as we can to join this effort and to continue to make people aware of it. And I think that's where it starts. It really does. 'Cause I don't think there's a big change doesn't just happen to everybody overnight. It starts as the seed crystals of knowledge and awareness and sharing of information and sort of building it. And that's where the consortium can help. We've done this before. We've had sort of a blueprint for 30 years experience with how to approach opioids. And I don't believe approaching them as a problematic class of drugs that have some accepted use.
Yeah.
And we're not advocating getting rid of opioids entirely, nor am I advocating getting rid of benzodiazepines entirely. I'm not advocating for that. If I didn't have Versed for my appendectomy, I probably wouldn't have done quite so well. I'm very glad there was a benzodiazepine for me to have 5 milligrams of,
Yeah,
during
you're going to
surgery.
want that. Yeah.
You're going to want that. It's really helped me. And so I didn't remember them cutting me open.
Right.
So I'm very glad I had it. But limited circumstances, limited
Yeah.
circumstances, I think is the key. And to teach doctors what those are and
Oh, yeah.
patient expectations about what they are. We have a corresponding problem on the public education side about people having sort of generally in this country the pill for every ill kind of mentality.
Right.
That if I
Right.
just get the right prescription, my life will be fine.
Yeah.
And boy, it couldn't be more wrong. There is no drug that's without side effects. There is no drug. There's no free lunch. Pharmacology, day one. Walk into day one of pharmacology. There is no free lunch.
Yeah, I mentioned that in my book. One of the lines I said was, I'm not taking a lot of blame for it, but I'm taking a little because, we want that pill.
Right.
We want the simple solution. We want the easy solution. We don't want to have to go to counseling. We don't want to have to read books. We don't have to learn how to meditate. We don't have to take yoga. We want the pill.
Right. Those other life changes are harder than simply taking a pill. Though knowing if you knew then what you knew now.
Oh, absolutely.
I don't think.
No, they should have been educated and known and told us what we were getting into when we took the pill.
Right. But and how that really can look, right? I mean, it's not so everybody knows, well, I could have side effects. People tend to think they mean like a headache or a stomach ache is what people tend to think when you say side effects.
Yeah.
And so we think a big part of this now is going to be increasing doctors' ability and patients' ability to be fully informed and really know what informed consent means and redefine what informed consent means for psychotropic medications that are potentially problematic. In my view, opioids, benzodiazepines, and stimulants. They should all be treated the same way. That we really need to do a better job of consenting people so they fully understand risks and benefits of controlled substances.
Yeah, and the truth is 95% of the people plus I work with didn't even go in asking for a medication. Like mine was actually prescribed for stomach distress. And of course I was given absolutely no warning, but I had chronic stomach issues and I assume my GP at the time thought it might be a stress-induced, a symptom or problem.
Mm-hmm.
But I didn't even really know it was an anti-anxiety drug when it was prescribed to me, let alone any warning. So.
Right. And that's a problem. Obviously, it's a problem. And we had a whole generation of doctors who were, some of them still practicing, that were really, it was much more of a paternalistic model where you talk to the doctor about your symptoms, they give you what they think the right treatment course is, and then you just go, your duty is to go execute the regimen that the doctor prescribes for you, not to question anything like that.
Exactly.
Things are changing for the better, which is patients know a lot more going in the door. And really we should be having shared decision making.
Right.
Where patients and doctors are discussing risks and benefits, and here's a treatment approach. And there's this other treatment approach, and there's this other treatment approach. Or if we don't do anything, here's what might happen if we just don't even do anything. Some people spontaneously resolve, some don't. You should know what's going to happen to me if I don't do anything at all.
Yeah,
What are my treatment options and what are the risks and benefits of each treatment option? And so I can pick which one is right for me and I can make a fully informed decision. And some people might still choose the same way, but I bet a lot of people would choose differently.
And I agree. I get some pushback sometimes from listeners, about working with a doctor. And one thing I always emphasize is it's just a good idea to work with a physician when if you decide to withdraw, because not only because you need the prescriptions and of course and everything else, but also you're going to have some symptomatology that's going to be kicking in, and you just need somebody who knows what you're going through, even if he or she may not be as benzo wise as we like to call it, but somebody who understands your desire to do that, agrees to help you with it, but just to walk along with you, because there's a lot of, I had 5 EKGs during my withdrawal because I thought I was having a heart attack that many times. It was nice to have a physician who, understood why I was asking for these tests and was willing to work with it because she knew that it was going to ease my anxiety by giving a simple EKG, and was going to keep me out of her office for another month or two.
Right.
You know, and having that person as a partner, and you, as you mentioned, it's finding that partnership that I think you're right. We leave the paternalistic model and go more into you're a partner with your doctor and you're working together on your health. But physicians are very helpful in that, and they are the ones that can prescribe the lower tapering of the medication, which is very helpful. But they also can see you through a lot of the complications that go along for some of us with withdrawal.
Of course, absolutely. And that's how it should work. The shared decision-making model has actually been studied and not, to me, it's kind of the biggest no-brainer. Like, why do we need to study this? But it's sort of it's been shown really well that people do a lot better if there's a shared decision-making model, because they're bought into the decision, they're more informed,
Absolutely.
their outcomes are better. I mean, it's all the things you would expect, but it's kind of like, hey, if we study it, the sun's going to come up tomorrow. And if I start looking at the east and look at that, it's going to come up, it's kind of know what the answer is going to be. But, it's been studied. It's as reliable as the sun coming up in the east and setting in the west, that if patients are working collaboratively with their doctor, they do better. So that's what we're hoping for.
Hey, I want to ask you one thing about Flumazenil. You familiar with that?
Yes.
I get reports, and I'm getting reports periodically. We talk about slow taper, and that, of course, is our standard. Of course, we often base on the Ashton manual, as I know you're familiar with. But the whole slow taper protocol is still our standard. But of course, you do get information coming through. The Peterson, of course, Jordan Peterson's story was a big part of that. But also other people that I've had email me and tell me that they've done, maybe not the ultra rapid detox, but more of a detox procedure using Flumazenil, not the one that Peterson went through. But is there promise? I know this has been tested for a couple decades and they've looked into it, but is there promise, in your opinion, from Flumazenil for maybe not a rapid detox, but for aiding in detox for some people coming off of benzodiazepines?
I think there could be, and I think the short answer is I think we need to study it. I think that it has promise for that, because obviously it's been used sort of as a reverser for benzodiazepine-induced sedation, or
why don't you tell everybody a little bit about what it is so they understand?
Right, and it's what's called a benzodiazepine antagonist, or it's a receptor blocker, where a benzodiazepine will attach to a certain type of receptor in your body and cause it to have an action. So it's an agonist. Flumazenil is an antagonist that sits on this receptor, occupies it, but does not activate those effects. So it's called an antagonist, much as though there is one for naloxone is an antagonist to opioids.
Right.
It's a pure antagonist. Whereas hydrocodone, oxycodone is an agonist, gives you an effect, and naloxone sits on the opioid receptor, kicks everything else off, and sits there and occupies the receptor but doesn't do anything. So it's good for reversing things like sedation. And what it's been used for so far has been things like if someone's doing benzodiazepine, either augmented or benzo alone, sedation for like dental procedures. Some oral surgeons will use benzodiazepines intravenously for sedation. And others will use them as an adjunctive to anesthetic of a different kind, and then they'll put on some benzodiazepine. But then if there's too much sedation, they can reverse that with using some of the Flumazenil and say, all right, we're going to reverse some of the effects of the benzos. And that's been done in this acute way. So I think there's promise for occupying these receptors, receptors not having people think they have to be stimulated, but having something occupying the receptor. And at least potentially, theoretically, that would be useful in the short-term acute kinds of withdrawal phase from benzodiazepines. We don't have a lot of studies in this regard to say, oh, it's effective and safe for a benzo withdrawal phenomenon, for detoxification kinds of protocols. We don't have a lot of data on that yet. But I think there's promise, and that's what I'm eagerly hoping that people are doing trials like that or will, and can find answers to that question. Just like with opioid detoxification, any sort of detox or medical withdrawal management is really important to have available as a strategy for a subset of the population that need it.
Right. And especially for extreme cases. I don't know if it's probably as recommended. I mean, not yet at all, of course, but once it's approved, maybe more for your average case of withdrawal and of dependence.
Right. And you could, there could be very low dose kinds of things. Depends on, there's a lot of different theoretical, I'm not offering up any evidence that it does or doesn't work for these things, but there's theoretical advantages to say, it's small enough dose, you might be able to do something that's adjunctive to the beginning stages of the taper for somebody who is on a high dose of oral benzos. Or if there is a rapid detox going on, maybe there does need to be something like this that's intravenous and could be for detox management for a 24 to 72 hour period, whatever it is, 1 to 4 days is a typical detax window, depending on the medication. So
I know a few people who are doing some of the slower, lower dosage treatment with Flumazenil and trying it out. So I think there's a couple of physicians even in the States here who have been working with it. So
and they can go off label. The doctors, it's legal
for
them to prescribe off label to try something that they believe in their professional judgment has rationale for being something that could work. And then if the patient is consented that, hey, this is what we're going to try, and here's why. They should be consenting their patient that this is why we're doing it. It's not on the label, but we're going to give this a try for this reason. And if the patient is informed and consents, and the doctor goes off label and does their job, there's a pathway for doctors to try that and do it appropriately, legally, and ethically. It's just not yet has enough evidence underneath it that we can make in these conclusions that we can say, hey, we should recommend this as the best practice.
And also, I want to make this clear, especially for people who are listening, is that it's not a miracle cure. This is something that can aid in a taper and in reducing your drugs and in coming off of them, but it's not in itself something that's going to fix benzodiazepine dependence.
That's correct. That's right.
I just want to make sure we make that clear.
Sort of thing. Right. It's a temporary short-term window thing. It's been used right now in the anesthesia setting, during and after surgery is where it's typically used now. And it's a very limited setting, but it's obviously as acute as it's going to get, because somebody's unconscious and we're trying to bring them back from maybe being overly sedated or having trouble kind of coming out of sedation. And it can accelerate somebody coming out of an over-sedated state. And that's a different phenomenon. But even then, it's a short-term thing, and it would be a tool in the toolbox to help somebody perhaps going through detoxification kinds of symptoms. If they're rapidly withdrawing from a higher dose of benzos, it could potentially be a bridge, like some people have if they're trying to come off a really high dose of opioids and get onto a different kind of medication like buprenorphine or something. We use them often, drugs like that, as a bridge to get them over to a stabilized tapering kind of regimen.
Okay, I got you. Before I'll let you go, I want to talk a little bit about the whole physiology side of things with benzodiazepines. Within the benzo community, we focus a lot on GABA receptors. I know that's one of the primary mechanisms that has been identified as being affected, especially the downregulation of the GABA receptors. But I also know, like with Dr. Wright, when I've had a few conversations with him, he often talks about peripheral nervous system too. From your standpoint, what do we know and what don't we know right now as far as the mechanisms of benzodiazepines that's leading to dependence and withdrawal complications?
Yeah, most of what we know, frankly, is in the GABAergic system. Most of our knowledge, 90% plus, is probably in the GABAergic system, is where our knowledge is. We do know there's other effects of benzodiazepines throughout the body. No drug is really unfortunately, no drug is terribly selective. When you stick this in the body, there are other things in terms of the central and peripheral nervous systems, potentially cardiac effects that can be some receptors in and around the heart, some receptors in the GI system, some that can affect the neuromusculature and the muscular system. So there's different kinds of things that we're seeing, but they're not as well studied as the GABA system and downregulation, because that's predominantly what we've been dealing with is the anxiety spectrum and regulation of anxiety and mood is what's been studied for 50, 60 years, whereas some of these others are more recent. But there's just dozens and dozens of receptor systems that benzodiazepines have some affinity for. So the effects are likely to be distributed around the body in different ways. We just don't fully understand them yet. And it's kind of a frightening answer in a way. But it's also the reality of it, that there's probably these diffuse effects that we're not really sure of. And we're doing the same thing with opioids, finding out what the cardiac effects really are, what the GI effects really are, what some of the peripheral effects really are.
Yeah, the GI ones are interesting. I noticed the other day that of the 67 podcasts I'd done previously, the one that's gotten the most attention and the most downloads is on benzo belly. So like you said, on the GI tract issues, I think that comes out as a big surprise, especially of the level of GABA receptors within the digestive tract, that the GI system is so affected for people going through dependence and withdrawals. And I'm talking reactions that last months and years for some people. What, as you mentioned with the GABA receptors in the GI tract, what happens? From your standpoint, scientifically speaking, what happens that makes that, become such a problem, and that food can be such an instigator of symptomatology?
Yeah, it's just an interesting thing. Digestion itself is a very complex procedure. It's regulated by a lot of on and off switches. So things that will promote gastric motility and stasis, things that promote acid secretion, things that are stressors independently. So it's interesting because stress and the mediation of stress, which is kind of GABA mediated, and 2 or 3 other neurotransmitters mediate stress. But stress in and of itself affects digestion, and that's where it in turn can affect acid production, and in turn can affect motility. So there's all these different systems working, and it's a very finely balanced system to regulate your digestive tract, much more so than people think. It's
Okay.
just a bag with some acid in it to digest your food. And it's a lot more complicated than that. And it just has a lot of nuances to it. So we think it's several things going on, both the direct effect on the receptors, but also some of these other effects that it can affect motility, it can affect acid secretion, and then just your level of stress. And if your stress isn't managed anymore and your anxiety goes up, then that can independently on its own, through an indirect pathway, start to affect your digestion.
Okay.
So it's kind of complicated, but many factors.
Right. And with the many different symptoms, I mean, one of the common things we hear all the time is that if you haven't experienced it, you can't understand it. And I think people that go through a lot of different medical conditions would say the same thing. But I think the severity, the length, and the broad range of symptoms is the one that's most difficult for us to get other people to understand the actual degree of what this is to go through.
Right. Totally.
And
agree.
yeah, and how do we get people to understand that better, I think is the question.
I really believe the keys are, counting and documenting and then elevating. It's getting people aware of it. So we have to have people who are willing to count and figure out how to better count and describe this phenomenon and how often it's happening, to have some studies to show how frequent this is, then to elevate this. And we need champions and we need awareness. We need kind of a similar playbook that we used, I think, with opioids. So we think we have some lessons in this playbook to bring to bear. That how do we get people engaged for doing a better job with data and developing the data to demonstrate how big this is? How do we start to raise awareness among prescribers? How do we start to raise awareness among the general public? Right. How do we work with legislators? How do we work with state agency folks? And start engaging them all and start raising their awareness so that in time we can start cross-fertilizing, trying new things clinically and building this. And it's hard because it really is. This is like eating an elephant. The problem is huge. Yeah. We're not going to solve it tomorrow, but we have to have a plan to try to eat this elephant, or we're never going to get this thing done, because we stare at the elephant and think it's pretty daunting, how are we going to raise awareness of everybody? How are we going to change laws? How are we going to change practice? How are we going to get doctors to understand? And it's a daunting challenge, but there is a way to do it. Okay. And I think we just have to start taking bites, start using the methods that we know how to do, start raising this awareness. And it's a lot of rolling up of the sleeves, but I think there are ways that we have shown that work that we can apply here too.
I'm going to ask you a question I probably get more than any other one, and that is, will I fully heal? I get this all the time and always try to help people understand, but it's a good question. What are the odds that there's still some of this lingering symptoms? I mean, I was on 12 years and I'm now 7 years off and still have symptoms of my experience. What are the odds that for people, even if it's a minority, this might be permanent? What do you tell people that, are asking will I be back to normal?
And the honest answer, as difficult as it is we don't know. Okay. That's the truth of it. We really don't know if there's permanent damage. It appears that a lot of this is reversible. Okay. That's the good news, is that's what it appears, that a lot of this is neuroplastic and that it is reversible. Okay. We don't know if it's 100% reversible or not. It's not well understood enough on life course of it and some of the changes to see what is and isn't, the extent of the reversal and how things manifest. So I don't really have an answer because I don't have enough data. The good news is it appears that many of these things operate in a plastic way. Right. And many of these things do seem to lessen and lessen and lessen over time. And, so I'm optimistic, but I don't have a concrete answer for people to say, oh yes, this will always happen. Or on the other hand, I don't say, no, you're never going to ever feel fully well. I can't say that either.
That's fair.
It's just kind of one of these where we're learning as we go along. Yeah. And we need to understand it better so we can give people the best informed answer. Luckily, we think that a lot of these systems that we're dealing with are plastic ones, and so it gives me cause for optimism.
That's wonderful. Last question. I just want to ask you if you have any closing words or anything you'd like to share with our audience before we close out this interview.
Well, I just think the first are that I've seen what you're experiencing. I've had the good fortune not to experience it myself directly, but I've seen it and I know that it's real. So understand that there are people that do know that what you're experiencing is real. And so that's the absolute truth. And I firmly believe that. Yeah. Second is that there are ways to address this, in terms of education and policy and practice. potential new medications to help things. There's alternative methodologies for dealing with stress in the first place and the reasons for using benzos. There's lots of developments there. So there's promising practices that we believe can help. And then there's ways to try to affect policy and affect system change that we really believe can help. The last thing I would say would be, do everything you can to be a voice.
Okay.
Attend meetings like these of Benzo Wise. Participate in whatever way you can with whatever advocacy organization or organizations that you can to amplify your voice so that you can and will be heard. And so that's what we need everybody to grab a shovel. That's why I used to, in the early days of the consortium, give out these little teeny plastic shovels at our annual meeting. And it was for a reason. It was like everybody needs to remember to carry around their little tiny shovel,
Right.
thinking this little tiny shovel is not going to move a mountain. But my little tiny shovel, if everybody else has their little tiny shovel, we can move that mountain. We all have to grab a shovel and lift as much dirt as we can. And I'm committed to wielding the biggest one that I have, but we all need to help. And I welcome collaborating with you.
That's wonderful, Rob. Thank you so much. And I want to chat with you just briefly after I close here, but I want to thank you so much for being on the show today. This has been a true delight. Your information is, I think, exactly what I was looking for this conversation today. And I'm so pleased to have you on the show. Thank you so much.
Happy to be here. Thanks a lot, Dave. Appreciate it.
My pleasure.
I just want to thank Dr. Valuck again for being on our show, for giving us his time, for speaking with us, and just having so much background and information to share. I learned a lot from this conversation, as I have from my other conversations with Rob as I've worked with him. These are the people in the industry, the doctors, the scientists, even people in the pharmaceutical industry who have a lot of knowledge, and when they start to see what we're going through, when we start to make them more aware, when we start to help them understand, I really believe we start to make a difference. And they start to help, and they help out with their knowledge, and their knowledge is vital to what we're doing, to our advocacy. So I thank them. I thank Dr. Valuck for his time, for all he's doing, and hope we'll have him on again here down the line. And that being said, let's move on to our moment of peace. But before we do that, allow me just 30 seconds for our disclaimer.
This podcast is for informational purposes only and should not be considered medical advice in any way. The host of this podcast is not a medical professional, nor is he engaged in rendering medical, health, or psychological advice, nor any other kind of personal or professional services. The views and opinions expressed by our listeners and interview guests on this podcast, whether read from textual submissions or presented in their own voice, do not necessarily reflect those of the Benzo Free podcast or of its host. Withdrawal, tapering, or any other change in dosage of benzodiazepines, non-benzodiazepines, or any other prescription drug should only be done under the direct supervision of a licensed physician. Our full disclaimer can be viewed on our website at benzofree.org/disclaimer.
And that brings us to our closing, our moment of peace. It's just 1 minute, and it's an opportunity to quiet your mind a bit before you return to the chaos of the real world. Please remember to only do this if you are in a safe place where you can relax. Close your eyes and let the world pass by without you for a minute. Our meditation today is a lighthouse meditation. We've done this one before, and I like to visit it periodically. Our lives, our minds, operate at a mile a minute. Thoughts come and go so fast, we almost don't have time to even know what we're thinking or what's next or what just happened. In today's meditation, we're going to raise our awareness of the thoughts in our mind. Thoughts come and go, and we don't always control them. But if you can learn to notice the thoughts, where they come from, when they arise, and when they leave, you can learn to manage your thinking a little better. Today, all we're going to do is to listen for our thoughts, just like our listening meditation last episode, where we were listening for sounds. Today, we're listening in our own minds for our thoughts, paying attention to them as they arise and pass. No judgment. These thoughts aren't good. They're not bad. They're just thoughts. and we can let them pass. If your mind wanders, good, because that's what we're paying attention to today. Let's get started. Close your eyes and relax. Take a deep breath in. Hold it for a second and let it out slowly. Let's do that again. Take a deep breath in. Hold it for a second and let it out slowly along with all the stress of the day. One more time. Take a deep breath in. Hold it for a second. And let it out slowly, relaxing your entire body. Now just breathe slowly and naturally. And open your mind to what may come. Be aware of your thoughts coming and going, with no judgment at all. Continue to do this for 1 minute. Our next scheduled episode is episode 71, and it'll be released on November 1st. Please, let us know how we did. I'd really like to hear from you. Keep calm, taper slowly, and take care of yourself. I'll see you next time.